So I work in the St. Antonius Hospital in Nieuwegein in the Netherlands, which is unpronounceable, but it's a heart center in the middle of the Netherlands. Usually we do about 2,000 open heart surgeries, and we focus a lot about innovation and transcatheter technology. These are my disclosures. So I'd like to start with a slide by Frank Lloyd Wright, stating that, the famous architect, stating that form follows function. That has been misunderstood, and form and function should be one, joined in a spiritual union. I think this is as true for the left ventricle as it is for architecture in general. But in reconstructing following post-myocardial infarction, it's reconstruction that follows scar. So we're talking about left ventricle scar as a target for heart failure treatment. So the scar tissue is afunctional, it's non-contractile, it can distort shape and hence function of the ventricle. It's a trigger for further progressive negative remodeling of the ventricle, and the tissue adds to an increased left ventricular volume. So after myocardial infarction, as stated to the right, there's thinning out, loss of contractile function and compensatory dilatation and increase in motion of the non-impacted or remote myocardium. And then the ventricle starts to dilate, and this can lead to progressive heart failure. Whether or not the infarction is completely transmural will determine, in a large part, whether a through LV aneurysm or a more negatively remodeled ventricle with global dilatation is the result of the myocardial infarction. So this is an interesting study by Warner, who did a lot of studies on PV loops in heart failure, and he depicted the different stages of heart failure, A to D, as stated by the American Heart Association, ACC. And you see throughout ventricular dilatation, throughout different stages or increasing stages of heart failure, always leads to increase in function, increase in volume. So if you summarize it, it would end up like here. So when you go from stage 0 or A to D, your volumes tend to increase more and more. So the procedure stems from the idea of conventional left ventricular reconstruction. This is an open heart surgical procedure devised by, well, started with Cooley with classical aneurysm surgery, and it was taken on and developed further by people like Manikanti and Vincent Dorr. The idea is to do an open heart surgical reduction of LV volume and reconstruct an elliptical shape. This would result in reduced wall stress and improvement in systolic function, but comes at the expense of, or the price of, a reduced diastolic function because of the increased stiffness of the ventricle. So here in summary is the procedure depicted. At the scar border zone, there's a suture placed, which is tied around a shaper, which was used to aim at an calculated ideal volume for the patient, and then the gap is closed over filled strips. Pretty much invasive procedure. So we started in 2016 with the live procedure as a less invasive alternative for our patients with ischemic heart failure. And we considered patients eligible for the procedure when they presented with symptomatic heart failure, at least New York Heart Association class 2 increased NT-proBNPs, and ischemic cardiomyopathy with ejection fraction of below 40%, all after anterior myocardial infarction. All patients should have a dilated left ventricle, roughly aiming at 60 milliliters per square meter of polysurface area, with either a or dyskinetic scar in the anteroseptal wall at the apex of at least 50% transmurality. So we use late enhancement MRI when there were no devices in place to delineate the scar, and possible because of ICDs in place or pacemakers, pacemakers. We used 4D CT as depicted here below. So we looked at wall thinning and akinetic dyskinetic motion to estimate where the scar area is and to see if the patients are eligible for reconstruction. And here's a case example of post-reconstruction. You see here are the anchor pairs in place, and you see there's no scar tissue remaining outside of the reconstruction. So here it is with motion. We tend to go to more and more to 4D CT because we can compare that during follow-up, especially when devices are in place, as a majority of these patients have. So here's post-op echo. It should run. So the procedure is performed through this, as shown before, through this mini thoracotomy on the left side. And here you see the fold where the external anchors actually are in place. So between October 2016, when we started this program, and January 2022, 30 patients were operated in a single Dutch center. Our program was put on hold for a little while because of COVID restrictions. So average age of the patients were 62 years, predominantly male, ICDs preoperatively in almost 50% of the cases. These are the rest of the demographics. NYHA class, is between 2 and 3, so let's say 2.8 in general. So this is procedural data. So we used on average 2.3 anchors to reconstruct the ventricle. On average 1 internal anchor and 1 to 2 external anchors. Skin-to-skin time is about 2.5 hours. Here's fluoroscopy time. We had 3 events, 1 lesion of tricuspid valve in the early experience, 1 conversion because of a wall-hugging organized thrombus that did get dislodged, so we had to convert it to open surgery to get the thrombus out, and then we used the anchor system to still reconstruct the ventricle. And 1 postoperative revision, which was interesting because, as we learned, if you plicate the scar tissue and you go way too much basal, posterior on the septum, and you tend to fold the segment in between into the right ventricle. This happened in one of our cases, so we had to go back a few days later because of RV restriction and failure to take out an anchor pair, and after that the patient recovered. Median duration of ICU stay is 2 days, and median length hospital stay is about 7 days. There's no hospital mortality, there were no strokes. In line what we just showed you, here's the intraoperatively 3D echo measurements of left ventricular ejection fraction is increased by 38%, and a decrease in end-systolic volume index by 35%, and a decrease in left ventricular end-diastolic volume index by 30%. You see that the left ventricular end-systolic volume index decreased more than the left ventricular end-diastolic volume index, which is in line with an improved contractility of the ventricle. However, as we all know, using echo, especially doing follow-up, especially in these deformed ventricles who are not symmetrical, echo measurements of volume ejection fraction is not pretty much accurate. So recently we started using LVOT VTI measurement as a surrogate or as a marker for cardiac output, and to do that for follow-up. So here are patients that had at least a follow-up of 3 years, which resulted looking at the long-term data. And here you see the LVOT VTI pre, and here you see the LVO VTI post. And in general, there's an increase of about 12%. Normal LVOT VTI for non-heart failure patients would be somewhere between 18 and 22. So you see here, majority tend to go near these at least measure of 18. Of course, because of this small series, p-value is 0.98. I think it has to do with the small group. But it does show that in long-term follow-up, there's an increase in cardiac output in these patients. So I said no hospital mortality, no strokes. There were 4 late deaths, and survival now at 5 years is 85%. There's 1 readmission only for heart failure in this duration, 1 for primary PCI and RCA, and 2 for ICD therapy. It rounds up to this survival. And then if I compare the live therapy to other more recent and older heart failure trials, I think it's interesting we could theoretically position the procedure here. Here's the DAPA, here's Paradigm, here's Emperor, here's Galactic. And you show, if I look at our own data, cumulative incidence at 2 years for cardiovascular death and readmissions for heart failures is about 18%. So it could be an interesting procedure to add to our patients with suitable scar. So here's the symptomatic status over time. So this is preoperatively, 5 patients in class 2, 19 in class 3, and 3 in class 4. And here you see the change in NYHA class over time. And there's an improvement in 21 out of 27 patients. This follow-up we did end of last year, so it's about 78%. There's no difference in 3 of these, and deterioration or mortality also in 3. So in general, large majority of patients do show important functional improvement over time. This was an average follow-up of almost 3 years. So to conclude, our experience, the LIFE procedure is a promising treatment option targeted myocardial scar for patients with symptomatic heart failure after large anterior and septal myocardial infarctions. And our single center 5 years result demonstrate the procedure is both safe and result in significant improvement in ejection fraction symptomatic status of the patients. Thank you very much.